Welcome to this deep dive, where we get straight to what matters. Today, we're looking at something really fundamental in healthcare.
Yeah, we're talking about quality
Right.
and safety for patients.
Yeah.
How do we actually understand it? And crucially, how do we make it better?
Exactly. It can feel, well, a bit overwhelming sometimes, can it? So many different tools, different approaches.
It really can, like a maze out there. But what we want to focus on today is something quite basic, but powerful. Just looking at data over time, watching how things change.
Right. And to really get a handle on this, we've gathered some perspectives from key players in the field. We're drawing on info from Joint Commission International JCI. They're a huge global name, been around over 20 years.
And also the National Accreditation Board for Hospitals and Healthcare Providers, NABH, doing really important work specifically in India. Plus, we've looked at the International Society for Quality in Healthcare, ISQA, another global perspective.
And to make it really practical, we also dug into a discussion from the QI Playbook podcast. They had a great breakdown of run charts versus control charts, which we'll get into.
Yeah, that's key for the practical side. And we also glanced at Supremediq, they're a consultancy, kind of showing the on-the-ground support aspect.
So our mission for this deep dive is pretty straightforward, really. We want to understand how these different organizations approach quality and, maybe more importantly for listeners, what role tools like run charts and control charts actually play in achieving those goals.
Basically hoping to give you some practical insights into how healthcare processes get monitored and hopefully improved.
Okay, let's get into this. Where should we start? Maybe the big picture.
Sounds good. Let's start globally. Joint Commission International, JCI, they are definitely a major player, been working for over 2 decades, and their mission, it's pretty clear, to enable and affirm the highest standards of healthcare quality and patient safety for all.
And their reach is just huge, isn't it? Operating in over 70 countries across different continents.
It is staggering. They've accredited and certified, I think, over 1,000 programs now.
Yeah.
And they've got this network of like 600 experts backing it all up.
Yeah.
That's a lot of collective experience.
It really is. What kind of things did they actually offer? Is it just hospital accreditation?
Oh, no, it's much broader. Yes, accreditation is big, but they also certify specific clinical care programs. They look into healthcare sustainability now, too, and even telehealth certification.
Telehealth, too. Okay, that's very current.
Right. And then there's their advisory side, helping organizations actually prepare for accreditation, improve quality management, infection control, how they handle meds safely, facility safety, even emergency management, policy stuff.
So it's not just like a test they come in and do. They're actively helping places build better systems.
Exactly. Plus, they offer tools for high reliability, online solutions, publications, educational resources. It's a whole ecosystem of support, really.
Right, comprehensive. And does it actually make a difference on the ground? Do hospitals feel the benefit?
Well, listening to some of the accredited hospitals, it seems so. We saw testimonials, like from Hong Kong Adventist hospitals. They mentioned it was great for team building, communication.
Okay, so internal benefits, too.
Yeah. And Burjeel Farah Hospital in the UAE talk about getting a competitive edge, more community confidence, plus better risk management, which is huge.
Makes sense. I saw Emirates Specialty Hospital mention the JCI Gold Seal helps reinforce their commitment to safety, giving patients confidence.
Exactly.
Yeah.
And Corniche Hospital, they've been accredited multiple times. They see JCI as the benchmark. It shows that ongoing commitment, not just a one-off thing.
So these aren't just bits of paper. They seem to tie into real improvements in how care is delivered.
That's the idea. Now, if we shift focus a bit, look at India specifically. There's the National Accreditation Board for Hospitals and Healthcare Providers, NABH.
Right, part of the Quality Council of India.
That's the one. They're focused on setting up accreditation for healthcare within India, really aiming to meet patient needs and sort of set benchmarks, raise the bar for the health industry there.
It makes sense to have that national focus, tailoring things to the local context. What about ISQA? You mentioned them earlier, the International Society for Quality in Healthcare.
Yes, ISQA. They're a bit different. Member-based, nonprofit, been around over 30 years. Their whole thing is promoting quality improvement worldwide.
How to do that?
Through various ways, actually. Education, sharing knowledge, best practices. They also have an external evaluation arm, the IEEA, and they support health systems directly, connecting professionals. It's very network focused across, I think, 70+ countries as well.
So building a global community around quality improvement.
Pretty much. They've got conferences coming up too, Sao Paulo in 2025, Dublin in 2026, looking at things like inclusive health systems, the future of healthcare. They're definitely trying to shape the conversation.
Interesting. And you mentioned Supremediq briefly, the consultancy.
Yeah, just as an example of another type of player. They help healthcare businesses, investors. And one thing they do is assist hospitals with getting that NABH accreditation we talked about.
Ah, so providing that practical, hands-on support for organizations trying to meet those standards.
Exactly. It shows there's help available on the ground.
Okay, so we've got this landscape of organizations pushing for quality and safety globally and nationally. But how does this translate down to, the teams actually doing the work? How do they track improvement?
Right. And that brings us nicely to the tools, specifically run charts and control charts. This is where that discussion from the QI playbook comes in handy.
Okay, run charts first. What are they, basically?
Think of a simple line graph. You plot data over time, say the number of patient falls on a ward each week. A run chart just shows you that data visually, week by week.
Just the raw data plotted out.
Well, usually with a key reference line, the median, the middle value of all your data points. You draw that horizontally across the chart.
Okay, so you plot the weekly falls and draw a line showing the median number of falls over that whole period.
Exactly. And then you look for patterns. Is the line generally going up or down? Are there sudden jumps? Specifically, you look for things like a shift that's usually 6 or more points in a row, all above or all below that median line.
6 in a row.
Okay.
What else?
Or a trend, maybe 5 or more points consistently increasing or decreasing. And you also keep an eye out for outliers points that look really unusually high or low compared to everything else.
So it's about visual inspection, really, spotting patterns against that median.
Pretty much.
Yeah.
The beauty is its simplicity. It's a great first tool for an improvement project. A team can put one up on the wall, track their progress, get quick visual feedback. Did our new falls prevention strategy seem to make the line go down?
Makes sense. Easy to understand. So how are control charts different then? They sound more complex.
They are a bit more statistically sophisticated, yes. They also plot data over time, but they add crucial extra lines,
Yep.
upper and lower control limits.
Control limits, how are those worked out?
They're calculated statistically from your own data. Usually they're set at plus and minus 3 standard deviations from the average or the mean of your data. So unlike the run chart, which uses the median,
The control chart uses the mean, the average, as its center line, and then adds these statistical boundaries.
precisely. And those boundaries, the control limits, represent the expected range of variation for that process, assuming it's stable.
Expected range, what do you mean?
Well, every process has some natural variation, right? Things fluctuate a bit day to day. That's called common cause variation. It's just the background noise. The control limits define the edges of that expected noise.
Okay, so anything within the limits is probably just normal fluctuation?
Generally, yes. But if a data point falls outside the upper or lower control limit, that's a flag. It suggests special cause variation. Something specific, something unusual has likely happened to cause that point to be so high or low.
Ah, so it helps you separate the signal from the noise, tells you when a change is likely real and not just random chance.
That's a great way to put it. It helps you decide if an intervention truly worked or if a sudden problem has cropped up that needs investigating.
So quick recap. Run chart simple, uses median, good for visual trends, early feedback. Control chart more statistical, uses mean, adds control limits, distinguishes common versus special cause variation, better for stability.
You got it. Let's use that surgical site infection, SSI, example. A team tries a new checklist. They track SSIs monthly. The run chart might start showing a downward drift after a few months. Looks promising.
But is it statistically significant? Or just a lucky streak?
Exactly. So then they switch to a control chart. If they start seeing points consistently falling below the lower control limit on the control chart.
That's stronger evidence. It tells them the checklist likely caused a real reduction beyond the normal ups and downs.
Precisely. And that kind of data gives them the confidence to say, okay, this works, let's roll it out everywhere.
So the advice is maybe start with a run chart, see what's happening visually, and then maybe move to a control chart for deeper analysis, especially for processes you do repeatedly.
That's often a really good approach. The QI playbook used a nice analogy. A run chart is like a stethoscope, quick initial assessment. A control chart is more like an ECG, gives you that detailed, sophistical picture of the heart's rhythm, or in this case, the process's stability.
I like that. Stethoscope versus ECG. Makes sense. Did they have a real-world case study on the podcast?
They did, yeah. They talked about a quality officer, Tanya Rawat, fictional name, but based on real situations at a place called MetroCare Hospital. Her team wanted to cut down medication errors in the ICU.
Okay, a common challenge. What did they do?
They introduced a barcode scanning system for administering meds, And they used both charts to track the impact.
Ah, perfect example. So what happened?
Well, first, they used a run chart to track missed doses after the system went live. And, as hoped, they started seeing that nice downward trend visually on the run chart. Fewer missed doses.
Good start, but not definitive proof yet.
Right. So then they crunched the numbers and put the data onto a control chart.
Yeah.
And bingo. The control chart showed several points falling below the lower control limit. That was the statistical confirmation they needed. It showed the barcode system wasn't just a fluke. It was genuinely effective at reducing errors beyond the usual variation.
That's powerful. Did it lead to bigger changes?
It did. Tanya apparently reported that this clear data was really persuasive for hospital leadership. They saw the proof. So they ended up expanding the system hospital-wide.
And the results?
A sustained reduction in missed doses. Something like 40%, I think they said. It's a great illustration of how using these tools methodically can really drive significant safety improvements.
Wow, 40% is huge. Okay, so based on all this, what are the main takeaways for someone listening who wants to improve quality in their own setting?
Well, first, don't be afraid to start simple. Run charts are accessible. Use them early in a project to get that visual feedback, see if you're heading in the right direction.
Okay, start with run charts. What's next?
Then, for processes that are more established, or when you really need to know if a change has made a statistically significant difference, consider graduating to control charts. They give you that extra analytical power.
Makes sense. Anything else?
Yeah. Think about your audience. Who are you showing the chart to? A run chart might be perfect for a quick update with the ward team. It's visual, easy to grasp.
Right.
But if you're presenting to, say, senior managers or a quality committee, they might want the statistical rigor of a control chart to back up a decision, like rolling out a change hospital-wide.
Good point. Tailor the tool to the audience and the purpose. And are these hard to make? Do you need fancy software?
Not necessarily. You can definitely make basic run charts and even control charts in something like Excel. There are templates and guides out there. Or, yes, there is specialized software too, things like QI macros, Minitab, SPC for Excel, which make it easier if you're doing a lot of this work.
So the tools are available. It's more about understanding when and how to use them.
Absolutely. So just to kind of wrap things up, it seems clear that both run charts and control charts are really valuable tools in healthcare improvement.
Yeah.
They just serve slightly different complementary purposes.
Run charts for that initial exploration and trend spotting, control charts for the deeper dive into statistical stability and significance.
Exactly. And the core idea behind both is understanding variation. That's so crucial for effective quality improvement. Knowing if a change you see is just noise or if it's a real signal you need to act on.
Yeah, separating the signal from the noise, that seems key.
Which maybe leads to a final thought for our listeners. Consider this. What could you learn by consistently tracking even just a small piece of data in your own work environment? Using even a simple run chart, could it reveal something unexpected, an opportunity for improvement in quality or safety that you hadn't noticed before? Just think about one process you're involved with. How might you start tracking it over time? What story might that data tell?